Welcome, everyone. I'm hoping that now that we're recording, people can hear us and there are some people online. I'd like to welcome everybody to the WBMT, or Worldwide Network for Blood and Marrow Transplantation, Nuclear Accident Preparedness webinar. We have an incredible lineup of speakers today, and it's an honor to be moderating this session with Adriana Seber, who will be joining us shortly. The way this will run is we will have a series of talks. Hopefully there'll be an opportunity to ask questions, although I'm not sure there will be, but you will probably find the content very informative. As you can see in our agenda, we have a talk about the Ukraine experience from Dr. Sergi Klymenko. We have a U.S. Radiation Injury Treatment Network by Nelson Chao, and Nuclear and Radiation Disaster Preparedness from the hematology community by Sharukh Hashmi. With that, I'm going to hand over our first speaker around the Ukraine experience, but I'd like to thank everybody for joining us. This is a very unusual, but also very topical webinar and close to the hearts of both Sharukh and I, who co-chair this committee. So thank you to everyone for attending, and I'll hand it over to you, Sergi.
Good afternoon, ladies and gentlemen. It's a privilege for me to take part in this very important webinar. I'm going to tell about Ukrainian experience, which is quite unique because Ukraine is now involved in full-scale accident, and Russian invasion started in 2022. The huge territories are occupied, and the battles are very active. Ukraine is now under the serious threat of radiation accident, and this might be not only tactical nuclear weapon explosion, but also radiation facility damage, strategic even nuclear weapons explosion as well. And we could also think about radiation waste storage damage. Ukraine is very, very dense with radiation nuclear facilities. We have a lot of nuclear power plants, a lot of reactors of different types, and not only operating reactors are the threat for nuclear accident, but military installations, research reactors, and storages of nuclear waste. And this threat is really serious because we see a lot of accidents which were quite near to the serious damages of existing nuclear power plants in Ukraine. Therefore, we are really serious in Ukraine towards preparedness to nuclear accidents of any types. And Ukraine is quite unique in terms that we are quite familiar with nuclear accidents. We experienced Chernobyl NPP explosion in 1986, and people in Ukraine are quite acquainted with radiation impact to human health. And physicians in Ukraine treated a lot of patients considered as radiation exposed. Not in high doses, of course, but there were also some people exposed quite highly. So what we have now in Ukraine available to treat patients with radiation damage. First, medical staff. Ukraine have a lot of physicians and nurses, but we should understand that during the war time, not only general population moved from Ukraine, but a lot of physicians also left country in Europe, US, Canada, other countries. So we continuously experience the leak of physicians. We have we all times sick physicians to open positions in my clinic as well. Hospitals. There are a lot of hospitals in Ukraine, and we should discuss that a lot of them were damaged due to war, and our Ministry of Healthcare reports a lot of hospitals damaged due to wartime. But I have to say that we still have quite a lot of hospitals ready to admit radiation-exposed patients, and we see the possible scenarios of radiation-exposed admission as, if it happens near the battlefield, the patients might first be admitted to mobile hospitals. This is the concept of war times, when we have medical and nursing teams near the battlefields, and then evacuation part of such mobile hospital. But this stage is mostly for sorting and first aid to be provided. Then patients, if radiation accident happens, should be evacuated towards forward hospital base, which is Dnipro city, and then we have several specialized hospitals in capital, in Kiev. Concerning drugs and consumables to treat radiation victims, I have to say that Ukraine is experiencing the problems with budget, of course, even with availability of some medical products, but more or less we should say that we have quite enough antibiotics to be ready for any possible scenario. We have quite a lot of donors and blood products, and the same I can say for fluid and electrolyte replacement. We have limited availability of growth factors. We do not have national stockpile or serious storage of growth factor, and bone marrow transplant for radiation exposed people is also not the real option in our country. Ukraine is quite developed for dosimetry, because we live quite a long time with consequences of Chernobyl accident, and we have really developed chain of radiation monitoring sites, which covers the entire country. Therefore, we will see quite soon if the level of radiation rises. However, the dosimeters in army are not in optimal number. We also have a very developed chain of usual laboratories. So dosimetry using CBC is really available in Ukraine. When war started, we devoted some efforts to improve knowledge of Ukrainian physician to deal with radiation victims, and already in April 2022, the first webinar was organized to teach physicians how to treat acute radiation syndrome patients. It was organized by Military Medical Academy of Ukraine, and we had several another seminars already in May 2022 with Duke University, written with WHO, and this was followed by another events. The last one was done by UABMT, Nuclear Accident Committee, in July 2024. And we also thought how we could improve the preparedness of our physicians to get ready for acute radiation syndrome, and decided that the most efficient might be to teach hematologists how to sort of treat acute radiation syndrome, because hematologists are usually dealing with cytopenia patients and are quite ready to deal with ARS patients as well. So we concentrated on how to deliver them the triage approach and distributed EBMT pocket guide on acute radiation syndrome patients assessment. In December 2023, we performed tabletop exercise organized together by Ukrainian Association of Blood and Marrow Transplantation and EBMT, Nuclear Accident Committee, during the hematological conference in Lviv. The aim of this tabletop exercise was to check how hematologists are ready. And we proposed them two scenarios. One, when radiation victims and witnesses are trying to be admitted to hospital after an accident in nuclear power plant, and we proposed hematologists to sort patients according to their CBC counts, and found that if such scenarios happens, hematologists will be overestimated the damage, radiation damage which might happen in patients. In one patient we discussed where radiation dose supposed not to be very high. Hematologists assessed the patient as really seriously radiation damaged and proposed him to hospitalize. 89% decided to act like this, which was overestimation of radiation dose, in fact. In another scenario, we proposed to our audience when we asked them to triage military people which got under the nuclear explosion near the battlefield, and we saw that hematologists underestimate our ability to treat patients and triage the patient hugely exposed as promising for recovery. So we saw that triage should be developed better in our country, and I suppose that this might be the problem for other countries as well. This is the point to be worked with. I also would like to mention that several documents were issued in our country to help physicians in dealing with radiation exposed patients. Already in April 2022, Command of Medical Forces of Armed Forces of Ukraine developed and issued recommendations on how to deal with radiation injuries, and it was distributed rather quick after the war started. And in this year already, Ministry of Healthcare of Ukraine developed the national guideline on acute radiation syndrome management, which was mainly based on WHO 2023 document on national stockpiles for radiological and nuclear emergencies. I guess that these documents are really helpful for physicians in Ukraine. So getting all together, I would like to summarize that the risks of nuclear catastrophe in the middle of Europe, not only in Ukraine, but in the entire Europe, is really very obvious. And the experience of Ukraine, which has already survived a large-scale radiation accident after the Chernobyl power plant explosion, increase the ability to withstand possible new radiation accident. However, we still see a lot of problems to be solved with readiness of our physicians for such scenario. And we certainly need additional measures to increase our ability, and we should concentrate on improvement of infrastructure, enlargement of GKSF stockpile, and further development of bone marrow transplantation program. Thank you very much for your hearing me, and I will be pleased to answer the questions.
Thank you so much, Sergey. That was a very interesting talk. We've got Adriana, who's joined us as well. I'd like to let the audience know that there is the opportunity to ask questions through the chat. So I will read questions from the chat if people enter them now. We have about 25 attendees, which is excellent. So please feel free to put your questions in the chat. What I might do in the meantime, before we move on to the next speaker, is to just get a couple of opportunities for some of the panel members who are on with us online to ask questions or to perhaps make comments. And I might throw it to you, Dietger, to see if you have any comments or thoughts given your influential involvement in the Ukraine.
Yeah, thank you, Nada. For those who don't know about the involvement of the WBMT, Damiano could be much more can give a better overview. What we are doing in the Ukraine at the moment, we are doing daily supervisory telemedicines and increased the number of allogeneic transplants in the last 3 years in adults from only a few, from 4 to 5 now to more than 100. So getting to a total of 340 transplants last year. So much better than before the war. I think the second point was is important that we have created the UABMT, but Sergi can tell much more about the UABMT that I can do. This is a transplant society involving also pediatricians. So I think that Ukraine has a very sustainable program now for transplant and also for hematology. We are making Thorsten Haferlach is making the blood tests, every kind of blood test in all hematological patients in the Ukraine. So we have built up infrastructure. Sergi, but you can comment on this, or Damiano.
Thank you very much, Dietger. Actually, the development of BMT program in Ukraine is quite successful, and the capacity of Ukraine is increasing. The allogenic BMT procedure are now available not only for children but for adults as well, and I guess that we will double the number of transplants at least several next year. After that, probably the progress will be slowly because we will be at the other level already. Thank you very much for your help, Dietger, and for the help of others from world transplant community.
Sergi, I have a quick question. You mentioned about the physician not being able to triage or to overestimate or underestimate the patients. Is there a specific program for nurses in Ukraine for training in radiation accident? We know that we're working with the nurses for bone marrow transplant, but it seems like the nurses would be a frontline people in case of an accident all over the place.
Thank you, Damiano. There is no special training program for nurses in terms of ARS triage. Probably we should think about this and As for transplant nurses, we are going to involve them into conferences we have on transplants and hematology, and probably they will be more involved after that in ARS preparedness as well.
So, Sergi, to be even more practical, if something happened today, you have, as I understand, a WhatsApp chat of a group of physicians which know about stem cell transplant, and they will be contacted within minutes, if this is correct. And the question is, how many beds do you have available for patients which are in aplasia? So these are all practical questions which you should perhaps mention thirdly, if you know them.
It's quite difficult to assess the entire number of beds available, but we have quite a lot of them. Even in our clinic, we have several departments which we will open in several months. They are ready, but not occupied by patients, and we still keeping these rooms for any accidents. We discussed this with military command, and they know how to send patients. And actually, all hospitals where hematology departments exist will certainly serve in case of accident, and will use the capacities of other departments to admit patients.
Okay, but these are not sterile rooms.
No.
So you will have about 50 or 60 sterile rooms, and if not, I think we should also make a bridge to other continents and societies which can provide some of them. So we made this some years ago in the UABMT about our 400 transplant centers, which can be contacted if it's needed. But again, a practical question. We have two possibilities. Nelson will speak about this later on regarding prediction of patients which are needing help. And we have the European approach, which is looking at lymphocytes. So what is your protocol? Are you looking at lymphocytes every 12 hours, or what is actually the plan?
I confirm that lymphocytes is the way we will use in Ukraine, because laboratories are widely available in the cities. We have a lot of governmental laboratories and private laboratories, which will certainly help. And that is easy for Ukrainian physicians. And we distributed EBMT pocket guideline to each hematological department. They have the tables how to assess patients. Probably we will have another exercise with them to increase their knowledge how to use lymphocyte count as the main triage parameter.
Thank you so much, Sergi. In interest of time, to make sure everybody gets an opportunity to fulfill their talk commitments, we have some comments on the Q&A. They're not quite questions, but they are very valid comments about radiation exposure that's uneven, open wounds that need to be treated, even though patients have been exposed to radiation, and the potential for over and underestimation of radiation exposure points to the problem of not looking at all organs or systems such as the CNS, gastrointestinal tract, bone marrow, and skin. And so perhaps this will be a point of discussion, hopefully by Dr. Nelson Chao, who will be discussing U.S. Radiation Injury Treatment Network. And I will hand over to you, and hopefully we'll have some time for questions. Again, please put your questions in the chat, and I'll keep looking at those.
Well, thank you for this invitation. This is a great it's always very timely given this environment we're in. I'm going to talk about the radiation injury treatment network we have in the U.S. This was a joint effort by the NMDP and the American Society of Cell Therapy and Transplantation. So we in the U.S., since this was formed in 2006, really have been focused on a dirty bomb or a nuclear detonation in the country, and less focused on radiological incidents, because the planning really is to think about what would happen with a true nuclear device. And I will say in the beginning that the RITN was not focused on triage or the events that happened acutely in the first several days. None of us who worked on this, we came from the hemonc and transplant setting, have any really knowledge of first responders. So we're really looking at urban nuclear terrorism type events. And so in a nuclear device explosion, there are going to be areas where patients were going to be immediately affected and die. There's a section where patients might receive 1 to 8 grade, and those patients would potentially have some which are salvageable and some which were not. And a lot of the modeling was done from Hiroshima and Nagasaki, which, if you remember, were mostly, it was an over-the-air explosion, and the structures were predominantly wooden houses. If you go to Hiroshima, you can see the metal structures still up. And so an explosion in a city in the US would have these concrete corridors of high rises, which would, in fact, give potential people inhomogeneous radiation, which affects how you can potentially survive one of these events. We think, as you do in Europe, about specific syndromes. So we think about the hematopoietic syndrome, the GI, the lung, and the neuro. There's a big move within the community here in the US to stop thinking about this as distinct syndromes, but probably as a continuum with a unifying hypothesis that endothelial cell injury in many of these situations really defines what's happening to those particular organs. And you can imagine that dose obviously impacts. This is how we've described in the past. And so if you are sitting in a metal desk in a building that's concrete and you get radiated, or you're walking by next to a car, that perhaps the amount of radiation you receive to your lungs would be quite different to your pelvis because of these potential areas which are shielded. The other piece we're working more and more are the issue about standards of care. So in our everyday setting in the US, it's a conventional standard of care. The relative resources are normal to excellent. But in case of a contingency or a crisis, the standard of care will drop significantly. And the real question we have is, what does those standards of care look like if this were to happen? So the situation we have thought for in these assessments is, if you know that there's really no significant radiation, probably up to somewhere between 1 to 2 gray, most, if not all, these patients can, after their blood test and a potential dosimetry test, be sent home and observed at intermittent intervals. Those who get between 2 to 6 gray will need more intensive therapy. There's also this issue about psychological support. If you end up with more than 10 gray, truly TBI in a situation like this, it's probably not, these patients are probably not salvageable. And the thing to remember here is we talk about only pure radiation, but if you look at combined injury, if you have burns or trauma, the amount of radiation that becomes lethal drops significantly. So you can probably salvage somebody with a 6 gray pure radiation, but if that same patient gets 2 gray plus a significant burn or trauma, that patient might not be salvageable. So as I said earlier, the RITN was founded in 2006 with a focus of looking at potential ways we could help. And we wanted to develop treatment guidelines for managing hematopoietic toxicity, educate healthcare professional, coordinate medical response, and provide comprehensive evaluation. So most of these hospitals work within NDP, and the effort is to receive casualties in case of a marotoxic injury. And we would accept patients to their institution, provide intensive support, treatment expertise, potentially travel to other centers to provide medical expertise. And what we really want to do is also collect data so that we could learn from some of these events. And as a very small percentage is to think that perhaps some of these patients could benefit from marrow transplant if they require it, knowing that in the setting of an urban event is the radiation will be inhomogeneous. The concept of operations we have in the US is an event goes off, there's first responders, which will get set up, as well as self-assembly centers that patient might be able to go together. There are places within the epicenter, of course, which will be a no-go zone because of the high radiation. And then from these state and local community health reception centers, there will be the ability to move these patients to a more specialized facility. And the time event of this is somewhere between 3 to 7 days. So these are the RITN centers. These really reflect the ability of these NMDP centers to take patients. The idea is an event goes off, for example, in Washington, D.C., that the victims will be triaged and then moved to other centers around the country. This just says the ability to move patients will be dependent on what's available at the time. And so the idea to give GCSF is to do as soon as possible, not necessarily in these RITN centers, but in the field, and then move these patients to these RITN centers. I just want to, this is a model of an animal model. So you can see that if you look at radiation alone, the ability to survive is this line in blue. But if you add a wound to the same dose of radiation, or you add a burn to the same dose of radiation, you can see the mortality goes significantly higher. And so this led to a significant amount of discussion among the RITN centers of what to do in case of mixed injury. Many of these centers don't have, many of the transplant centers don't necessarily have a burn center. We probably all have surgeons for wounds, but to try to understand what happens in the setting of both inhomogeneous radiation as well as combined injuries. Our guidelines is to follow the standard approaches for patients with bone marrow toxicity. So we want to use irradiated leukoreduced transfusions, antibiotics, IV fluids, GCSF or GMCSF, hospitalized when needed, and then look to see whether new mitigation approaches. We have developed a standard operating procedure, standard mission orders, data collection. We've trained about, we probably trained close to 40,000 staff now. There is a 2-day training that's done by the Oak Ridge folks in Tennessee. We have HLA typing laboratories, which can type around 10,000 per week. And then we have this internet-based unrelated donor cord blood search. Probably the most useful tool we have is this REM, which is the Radiation Emergency Medical Management. It's rem.hhs.gov, and it does have a lot of tools in there that you can use just in time. For example, this is one example of just looking at dosimetry, looking at time of onset of vomiting, lymphocyte depletion kinetics, and then dicentric chromosome assays. All these treatments we've developed are based on extrapolation on radiation accident victims and animal studies and patients with cancer. We would do daily CBCs looking at the total white count and lymphocyte count. There will be geographic dosimetry, so most cities will have dosimeters which are built into the infrastructure. And then the hope is to be able to apply new biodosimetry approaches. Many are being developed looking at genetic signatures, for example, or proteomics. Most of these within the REM, this is one picture of the REM website. It looks at what we would consider the radiation dose of at 5 grays. We would certainly want a prophylactic antibiotics, cytokines, and at that point, probably not consider stem cell transplant. And the profile, of course, is that about 90% would have trauma combined with injury, so treatment would not end up in these RITN centers. 10% would have radiation only. Well, our estimates in an event in an urban area in the US would be that we would probably end up with thousands of patients needing some intensive support. So in this open source estimate, about 18,000 would require intensive inpatient support, and out of that, a small percentage would potentially need a bone marrow transplant. I mentioned this earlier, the primary focus is on antibiotics, on hematopoietic growth factor. We do have a variety of decorporating agents, and then we have developed an order set for hospitalization, which you can find at the REM website. We do have a data form which will be incorporated to the standard NMDP collection. So, one of the feedbacks hopefully would be live as we collect data. We still have a lot of work to do. The current capacity of RITN is about 13,000 if everybody gets activated, and it doesn't quite meet the estimates of the total number that would be needed in case of one of these events. We have a lot of educational grand rounds which we provide on a yearly basis. We do scenarios. We do have treatment guidelines, which are available on the website. And we have, since 2006, have done a lot of teaching. The education goes from physicians to nurses, actually to facility support people if they are interested. One of our concerns is if this happens and the nurses and the people taking care of the linen and the trash don't show up to work, that is a major problem. So these are the websites for the treatment guidelines. There are actually a significant amount of these. A lot of this is just-in-time education, which can be quite helpful. So summary, there are a variety of incidents. I think hematologists, oncologists, and stem cell transplant experts will be called upon. And then communities distant to disaster will be necessary for all these casualties, maybe not just in the US, but probably some of these patients might need to be moved to Europe or South America. We do have one just-in-time training for clinicians, which is 16 minutes long. It's very quick, but it does hit all the necessary points. And this is my last slides. It takes a village, so we have lots of people that partnered with us over the years to put this together. So thank you for your time. I'm happy to take questions.
Thank you very much, Nelson. Thank you. It was wonderful talk, wonderful work. Hi. I'm sorry I couldn't get connected. I was desperate. There must be a nuclear accident in Brazil. Thank you so much. It's wonderful, and it's wonderful to have resources for you and for other countries to use and to try to get prepared too. I couldn't see any questions in the Q&A session. Can you see, Nada?
There are no questions in the Q&A. They've all been cleared. So we can potentially do some internal to the panel, maybe.
I have a question that maybe will be for everybody, but maybe Nelson can. I imagine, and in the case of a nuclear accident, in addition to the disaster, and there'll be a lot of internal migration of people trying to escape from one area to the next one, and causing a lot of issues, overwhelming areas where people will all go to, and maybe even countries if the accident occurs at the border so is there any preparation for that? That would be true for any country, but in the United States.
Yeah, the CDC has guidelines which really tell people to shelter in place. So if you are in a building and this happens, you are going to be much better off sheltering in place for a few days until the fallout passes. I think that your concern is exactly what's going to happen, is that people will get in their cars and start driving, and there will be no roads, right? So the people who were out will be a flash, which they will be blind. So they won't be able to see. These cars will crash in the freeways, and they won't be moved. And people trying to get on the roads to get out will have nowhere to go. And then they will sit out in the open as the fallout comes through. And so the big push by the CDC is to tell people, please shelter in place, listen to the radio, to the news, because if you go out, you're much more likely to be harmed than to make it.
And would radio work at that time?
So the radio will work outside of the flash, in the areas where the explosion goes, all the electronics will be fried. But the cell towers will come back on around the area. Most of the area around, probably within 5, maybe 10 miles will be okay.
We do have 2 questions. The first one is from Dr. Andrew Salner. And does your lab infrastructure have capabilities of doing cytogenetic and DNA-based dosimetry on thousands of individuals?
So there is the folks at Columbia have this machine called Rabbit, which is automated Dicentrix, which can probably do somewhere about 8 to 10,000 in a week. So that's not quite enough. And I think the new point of care genomic can be done within an hour in tens of thousands of patients.
Thank you. And Dr. Arno Genzer, who is going to do the decontamination, since you'll not admit a patient to the hospital who's not contaminated.
So the decontamination will probably be done in the field as these patients come to these mobile units. And if they're not fully decontaminated, they would get decontaminated before they would come to the hospital. So almost all hospitals will have a radiological unit set up to try to do this.
All right, thank you. Thank you. Would you like to pose any other questions now for Nelson?
May I ask you one? Nelson, what about new biodosimeters which were under development in recent years? We are still talking about CBC and metaphases, but what about something new and more efficient? Does it exist?
So there's probably about 5 or 6 different point of care, a finger prick look at either DNA signatures or proteomic signatures being developed. There has been several which have made it to the FDA, none of which have cleared yet. And so the FDA has been a little bit difficult in that they want a biodosimeter that is plus or minus half a gray up to 10 grays, which I think biologically is not possible because the curve decay, as you get to higher dose of radiation, the noise becomes too high. But it's close.
Thank you. Thank you very much. I think in this tough time, would you like to say something, Nada? No, we'll have to move on. Yeah, thank you so much, Nelson. And the next presenter will be Dr. Sharukh Hashmi. He is Professor of Medicine at Mayo Clinic and Director of Research at Department of Health in Abu Dhabi. And he'll talk to us about nuclear and radiation disaster preparation for the hematology community. Thank you so much, Sharukh.
Thank you very much for having me. I'm hoping that you can see my screen and also.
Yes, we do. Perfect.
Perfect. Sounds good. So a great session. I've got a lot of disclosures, but none of them are relevant to today's talk. I do not represent any organization. These are my own personal views. The job is a little bit easy because both Sergi and Nelson have outlined the important parameters which we need to look into when it comes to radiation and the concept of grays and the dose that goes up and dose response effects. But this slide is actually emphasizing on the fact that it's not just the medical community, it's everybody who's responsible for radiation protection in one way or the other. Because if you go from bottom all the way up, actually the astronauts are very few who go all the way to ISS and beyond. That's a small group actually who are exposed to different types of radiations. But then we've got many other occupations which actually increase the risk of radiation exposures. Then we've got nuclear power plants. And as you know that today there are approximately 440 or 445 nuclear power plants in the world operating actively. Some of them, there were more actually, some of them are shut down. New ones are opening in different countries. And Fukushima was one of the examples, but there's actually 440 right now. There has to be a nuclear disaster or radiation disaster planning for each country which has got a nuclear power plant. And the people who work in them are the most vulnerable actually to be exposed if an accident were to happen. And there are only 32 countries out of 200 which have got those power plants. Then the medical applications is something I don't need to tell this community. The nurses, pharmacists, physicians, many of the people on the call, scientists on this Zoom webinar, we all have to go through some training, some emergency trainings when we join a hospital or a clinic, because the radioactive spills can happen. And currently the many facilities have radioactive treatments for different cancers, for example, thyroid cancer and many other cancers as well, not just radiation therapy units. But the natural radiation exists. All of you know about the uranium in the mantle and the crust of Earth. The radon is actually a product of uranium, and radon has got a very, very long half-life as well. The uranium has got like thousands of years or even more half-life, which stays actually for a long time. So all of us actually do some testing in those areas where the government requires the testing of the soil for radon. But that's one of them. There's many, many other radiation sources that happen. Some of them are unnatural, and some of them are natural radiation, but this is natural radiation is present and we all are exposed to them, as you have seen in the previous talks. I'm going to go over that in a little bit more detail here in this slide. As you can see, chest x-rays and other x-rays give a little bit radiation, but 2.4 millisievert of radiation is on average for adult studies done are biased because they're done in developed countries. So we do not know exactly the actual radiation exposure per year on people in majority of the developing countries. But suffice to say, it would not be significantly higher than at least 10 if you even think about the cumulative exposure over a year from all natural sources of radiation. One of them actually I talked radon, the other is galactic cosmic rays, which coming from outside the solar system typically, and those are the rays which actually are deflected through the magnet of Earth called magnetosphere, and that's where you see the northern lights. So those rays, there's some exposure on Earth's atmosphere as well. And as you go above, you can look in the millisieverts, or you can look into the centigrays. There are different ways of looking into it. I have the slide for centigrays as well to be congruent with what Nelson has presented in the previous slides. But as you go up, there's a lot of effects that happen, and rightly so. It's not important to focus only on the hematological system, because when the patient gets worse, it's a lot of organs that one after another start getting worse. For example, if the GI tract is gone and there's a lot of mucositis, nausea, vomiting, what's going to kill them is actually not the GI and not the vomiting, nausea necessarily if they're getting IV fluids. It's actually the sepsis, neutropenic sepsis. same phenomena that we've got in bone marrow transplant patients when they get the BSIs, the bloodstream infections because of the GI tract damage by conditioning regimen or by graft versus host disease. And then you go up and the radiation doses are lethal at a point. We've got good evidence from the animal data as well as historical data from the A-bomb survivors. And of course, the Chernobyl data is out, many publications for that. So keeping in mind what the hematology community needs to know, Bob Gale, who is one of the foremost authorities in the world on radiation and nuclear disasters, he and I and Jim Armitage, we published this paper. We actually put in very simple tables for the hematology community. That's why we published in the Hematology Journal of emergency responses. We did not go over the parameter and the initial decontamination details, which, as Nelson has mentioned, are not necessary our area of expertise, but there are teams which are looking at every single step, and they have the parameters for 1 kilometer, 2 kilometer, 3 kilometer, 5 kilometer, and then there's actually a decontamination unit in the hospitals as well, and that's suddenly set up immediately when a disaster happens. There are already so ad hoc set up drills that happen in large tertiary hospitals all the time, actually, to be prepared for these disasters. We did show this graph to simplify things. Between 2 and 12 centigrades, grays, actually, there's a lot of support that's needed, and nobody knows actually that if you were to wait for example 6 months and what they're going to be autologous recovery or not. For example, if somebody got exposed to 8 grays or not. I mean, a lot of data comes from bone marrow transplant studies as well, that when, in the past, the 14 grays and 15 grays in the literature have been applied actually for TBI, for bone marrow transplants, but, then they came down 1200 centigrays or 13.5 or 13.2 as a cutoff for myeloablative, above which there's going to be a lot of damage, but it's not suddenly something happens. It's a continuum of actually radiation dose, 200, 400, 600, 1,000, 1,200 grays of TBI, which this would mimic mostly, actually. It's not that somebody gets exposed to a certain area of the bone marrow, like the pelvis, which is 30% of the marrow stem cells. It's actually the total body gets exposed to radiation when actual disaster happens. The CNS, unfortunately, affects if they're at 15 grays. I mean, they're irreversible at that time, but a lot of support is needed. I'm going to go over when to do the bone marrow transplant, because that's the most controversial question in the light of new data that's coming in survival of the people with autologous recovery, in which they had looked at the chimerisms. But this score is not our score. This is a classic WHO consensus score, score 1, 2, 3. As you can see, there's many parameters. There's many parameters which are clinical, but also laboratory findings. And just for the hematology community, you do not stop at hour 48 for lymphocyte count. You're going to do daily CBCs anyways, because it's actually the decrease in the lymphocyte count which can predict a lot of things. However, you need to continue doing it because a lot of things happen secondarily in the real world, like sepsis and many other things that ensue in these patients, especially the ones who've got burns, which affect the hematological parameters. But this is a very classic studies of lymphocyte counts at 1 day and 2 day and 3 day counts. But this is tip of the iceberg. We do many more sophisticated techniques for the assessment for the need for bone marrow transplant in these patients. Then came our paper of WBMT from our committee, and Ray Pulse and Nada and I are the co-chairs of this committee, but everybody helped, and a lot more people really give good suggestions for this paper for Ukraine. If something were to happen, how can we work together? As Nelson had showed, that the whole community is involved, like the WMDA has actually the donor HLA records for more than 40 million people, I think, at the moment, from all registries. How to activate this, but also be very, very fast in actually getting the matching done in case there's no immediate match found there at the region or a cord blood unit. That's going to be our job, actually, as a whole community, to work together Be the Match and all the European and Brazilian and Asian and many other societies together to actually get the message for the people who need it. Now, to decide who needs it is a different question coming up. But this requires more than just the donor societies. This requires the labs. And there was a very nice question: what happens with a massive nuclear disaster? And there's a war which incorporates many countries, and which lab is going to do it? Because the labs in those countries which were prepared are lost. That's where these kind of collaborations come in to actually work together. And obviously, the IAEA and WBMT, WHO collaboration is going to be critical to make things successful if this were to happen. And the Metropole data is indicating that you need to be assessing at different levels. These are 4 levels, and this is online, actually published. This was our paper in hematology. We got it from them, actually. The lymphocyte, granulocyte count, platelets, and the hemoglobin all are part of the scoring that we do. And the tertiary care hospitals, which are prepared for radiation disasters, are actually well-known different scales in which they need to treat the patient or triage the patients to ICU, or when to put them in step-down unit when you see things are getting worse. This is depending on infections as well. Now, excellent question was asked about Dicentrix. We're looking at different mechanisms at the moment. As you can see, the aberration analysis on the left for cytogenetics and stable aberration analysis, and then cytokinesis-based micronucleus. These are all different techniques. We don't have time. Actually, we're almost up to the time. But just to let you know, this has been published for biodosimetry in cases of these kind of disasters, and they all have advantages and disadvantages. And if you have none of those available, then the most classic techniques of cytogenetics, of G-banding, karyotype, something is better than nothing. And in real world, we won't have ideal labs to do perfect testing for a majority of the people. We've got to do the best we can. We got to do, if you've got only single cell clonal assay left, which is kind of rare, but I mean, that's a very sophisticated technique, then be it. I mean, if you cannot get the samples anywhere, because even to transport the sample to a chopper, there's a decontamination technique and rules and regulations for that. And for international borders, even much higher regulations when this happens. So we published and tried to make things easier and simpler by actually putting this table in our paper of Ukraine disaster from WBMT, the pre-transplant, the same cytokines, antibiotics, transplant eligibility needs to be determined very quickly. But even if you're not going to go for transplant, you got to prepare for transplant, right? I mean, that's a very important thing. Even if you think there's a good chance of autologous recovery, there's no point of not doing an HLA typing for that person who is exposed. And then transplant considerations happen. So let me end here because we want to finish on time. When a nuclear disaster happens, it's hard to predict the exact damage to the marrow, because even the most sophisticated biodosimetry techniques may not ideally capture the exact grays that a person is exposed to, whether it's 2.5 grays or is it 5 grays. Sometimes we find out a little bit more information later on, actually. And by the way, type of the exposure is also important. The duration of the exposure and the distance from the exposure is important. And we're talking about nuclear disasters, but in reality, there's a lot of radiation poisoning that can happen. Uranium, totally different dynamics. Polonium, well, different world. I mean, how to get the polonium is a very big question. I mean, that can happen, certainly. If that kind of exposure happens, then that's kind of death sentence anyways. But if somebody were to survive, very different dynamics of the bone marrow when that happens. So, and the third thing is prepare for potential allogeneic transplant. You don't have to do it. This is going to be the next bullet point. Which patients to transplant or not is actually an MDT approach. And MDT is not the typical hospital MDT. It's the IAEA, WBMT, WMDA, governmental experts, local bone marrow transplant experts, and the radiation biologists deciding on each case would be ideal if that kind of team were to happen. And that's where we all need to work together. Today's message is not the focusing on WBMT. It's actually focusing on how we should help each other, because in real world, things are so chaotic. It really destroys the whole planning because of unknown factors and external factors. And lastly, we put this in our paper as well: best to prevent a nuclear disaster rather than treat the post-disaster complications. And then that's where the preparation comes for the accidental disasters. Non-accidental and human-made intentional wars, that's something that's beyond our scope, but at least we should be a voice against and actually the things which are very controversial and can put human lives in jeopardy. But from our side, we should be supportive of the preparation for tertiary care hospitals for a nuclear and radiation disaster. With that, I'm going to end and give it back to the chairs of this seminar. Thank you.
Thank you so much, Sharukh, and it's a wonderful note to end on. We are we're literally 1 minute beyond the hour, but I'd like to just make one final comment. We don't really have any questions in the chat. Enough to say that it is wonderful that there's a group of people who are interested in prevention and managing and mitigating risk. We've seen in COVID how things can get out of hand and communication channels break down. I perhaps might ask one question to the group that spoke here today. What is the engagement with radiation oncologists who are familiar with some of these complications in our MDT teams that discuss these issues? And I'll hand it over to any of you who want to give a quick comment about, how many radiation oncologists do we know working on this field as colleagues that we deal with, particularly in the hematology space?
Well, I can answer just a quick one. There's a lot of radiation oncologists part of the IAEA teams, and also the WHO teams, which are preparing for radiation disasters. Within the hospitals, the radiation oncologists should be involved in MDTs if this were to happen, but also the radiation physicists should be involved as well, because their knowledge of the physics of the radiation exposure is excellent, actually. So the radiation physics is a key person to be involved in these kind of MDTs. And there's always a radiation physicist in big tertiary care hospitals. Thank you.
Thank you. I love, ending on the working together part of things. I can see that Arnold Ganser says, great webinar. Thank you. That there is a team in the German military that does this. I think having this conversation is excellent. Advocacy is fantastic. It's a pleasure to work with you, Sharukh, as a co-chair on this committee, because prevention is better than anything we can plan for. We can't mitigate that. And I'm so grateful to be part of this webinar, but also part of the WBMT and the amazing collaborative people that work across the world and network across the world. That is a skill and a passion. So thank you all for making the time to be here at whatever hour it is where you live. And I will close this meeting by saying thank you again, but most importantly also congratulations, Damiano, on being our president. Thank you for taking the lead on the future of the WBMT. Thank you, Adriana, for coaching.
Thank you. Thank you so much.
I want to just
thank you for everyone.
A future webinar will be interesting to follow up on this one. How to protect the donors of bone marrow transplant after a radiation accident, because that will be a completely different topic. People will be typed and the donor actually has been exposed. So that will be for future discussion. Thank you, Nada. Thank you, Adriana. Thank you, everybody.
Thank you so much. Thank you.
Thank you very much.
Bye. Thanks.
Thank you, Adriana. Thank you.
Thank you, Nada. Thank you, teacher. Bye.
Bye. And Vera, thank you for your great admin in the background. Thanks.